Hello Facebook, thank you for joining us today. We're going to be chatting with Dr. Sunny Ibarra, our Chief of Cardiothoracic Imaging here at UT Southwestern, today about cardiac calcium scoring. This is an especially timely topic because it's Heart Health Awareness Month. Before we get started, I just want to remind everyone to make sure that you ask your questions in the comments section of your Facebook feed, and be sure to like and share our chat. This is a very timely topic, and we want to make sure that everyone gets a chance to watch it who needs to see it, and that we get some good traction here. Before we begin, I want to thank our partners in the Office of Communications, Marketing, and Public Affairs for co-sponsoring today's chat. Dr. Sunny Ibarra is the past president of the Certification Board of Cardiovascular Computed Tomography, and he's the president-elect for the Society for Cardiovascular Computed Tomography. So that makes him our expert of the day. He's well aware of the benefits of cardiac calcium scoring. And without further ado, let's get started. Dr. Ibarra, can you explain to our audience what cardiac calcium scoring is and how it differs from coronary CT angiography? How accurate are these tests?
Don, thank you very much. This is a very important distinction. Let me go back to the beginnings of calcium scoring. In 1990, Arthur Agatston and Warren Janowitz and others have put out the first paper on calcium scoring. They have used back then electron beam CT, today we use mechanical CT, to look at calcium in the coronary arteries. No contrast material is administered when you do those tests. You don't need an IV, intravenous line. You would be lying on a table with EKG leads on your chest, and a CT scanner would acquire images. Now, the calcium score will tell you if you have coronary artery disease. What we're looking for is calcium in the wall of the coronary arteries. Coronary CT angiography, or CTA, is different in that for that test you would put an IV in and you inject contrast material, and you're usually asked to take medications to slow the heart rate down and to widen the coronary arteries. For calcium scoring, you don't need any of that. What
does the CTA do that the coronary calcium scoring does not? What are you looking for with a CTA?
Both tests look at the effect of coronary artery disease, or CAD, and the effect is buildup of plaques. So you can liken that to a house that was built in the 1860s, where the pipes have a buildup of plaque causing blockages. So the water pressure may be very low, and the amount of water coming out of your faucet may be low. Now, the CTA looks for a narrowing in your coronary arteries, which are the arteries that go to your heart muscle. The heart muscle is what makes the heart pump, and it requires oxygen, and the coronary artery delivers the oxygen to the heart muscle. And it looks for a narrowing or a blockage, and in order to do that you need intravenous contrast. The calcium scoring is different. It only looks for the presence of calcium, which is something that gets deposited as you get atherosclerotic disease of your coronary arteries. In the beginning, you may not have calcium in every plaque, but towards the end, as the plaque ruptures and stabilizes, you may find calcium deposits.
So calcium plaque, this is plaque that has calcified or hardened? Is that a good way to describe that?
That's a great way to describe it. Calcium score looks for the hard elements, the calcium inside a plaque that previously in life would have had no presence of calcium. Now, that brings me to another point. Calcium scoring is done for risk assessment, to help your physician to assess your risk of a future heart attack, and then maybe change medications today to adjust that risk, or not just medication, lifestyle changes as well. So calcium scoring is generally done in people that are not symptomatic, that say don't have chest pain or other symptoms of coronary artery disease. Coronary CTA, on the other hand, where we're looking for blockages, that is done in people that have symptoms. The most common symptom would be chest pain, in certain situations, and it is done to exclude the possibility of having a blockage. So the situations in which you would do one or the other are very different.
Now, I've actually had members of my own family who, as I was growing up, it was always said that they died of hardening of the arteries. I don't know if that's an accurate description of what we're talking about here, but when we talk about the buildup of calcified plaques in the arterial walls, is that essentially what we're talking about? That there becomes such a buildup that that there becomes a complete blockage?
Yeah. So that is one way of thinking about it. In the process of getting atherosclerosis, atherosclerosis literally means hardening of the vessels. In that process, you deposit calcium, and you can think of it as hardened. Some people differentiate soft plaque and calcified plaque. Soft plaque is not a term we like to use. We call it non-calcified and calcified plaques. But it's looking at the same principle. Now, important distinction. With calcium scoring, we're looking at a much earlier time, maybe years before there's a blockage and people get chest pain or symptoms from it, where with the CTA, you would think about that when people start getting symptoms.
Is it inevitable? Will everyone have some amount of calcified plaque in their arteries?
Okay, so
that to eventually develop that?
That's a great question. Coronary artery disease is extremely common, or coronary artery atherosclerosis is extremely common. You could also ask, well, what is a normal result, and is everybody going to be normal? It's a very difficult question. There is no such thing as normal. Coronary artery disease will be measured with an Agatston score, named after Arthur Agatston, the first author of the original paper. And the score can be either 0 or non-zero. And if it is non-zero, it's an open-ended number. It can go into the thousands in some people. But we like to think of it as scores of 1 to 10 as a very low score, or 11 to 100 as a mild score or intermediate score, then 100 to 400 at moderate to severe, and above 400 as excessive. However, much more goes into that. Your referring physician, when you get a calcium score, will take the actual Agatston score into account with other risk factors, and they may reclassify your personal risk.
I see. Well, we've got people asking questions already, so I'd like to take one from our audience. Diane has asked, do these tests replace what was previously the heart catheterization?
That's a great question. A heart catheterization, there are different types, but I believe what she means is a coronary artery angiogram cannot be replaced by a calcium score. The coronary artery, the invasive coronary angiogram, also looks for a blockage. Now, perhaps the question was, well, does the coronary CT angiogram, not the calcium score, can that replace the invasive coronary angiogram? And the answer to that is much less straightforward. There is some thought that you look at now we're talking about chest pain, and your pre-test probability, or your chance of having a blockage, is moderate or high, you would still go straight to the cath lab for your invasive angiogram. But if you are a low or maybe low to moderate risk, coronary CT angiogram is a reasonable choice, and if it were negative, it would safely prevent you from going to the cath lab. There are studies that have looked at how often in the cath lab we have non-obstructive disease, which means no blockage, and the number is very high.
Can you talk a bit about the radiation involved in the cardiac calcium scoring test? Because it is a computed tomography exam, it uses CT technology, which does use radiation. Can you talk a little bit about the exposure risk involved with the cardiac calcium score?
Right. So CT calcium scoring uses computed tomography, which basically is an X-ray machine shining X-rays through you. Think of it as shining light through you, just at higher energy. And it does that not just from one direction, but 360 degrees surrounding you. So it uses X-rays, and the dose is usually quoted with 1 to 3 millisieverts. What does that mean? Well, if you are alive for a year in this country, you'll get anywhere from 3 to 5 or so millisieverts, depending on your location, just from being alive and getting what's called background radiation. So the radiation dose from the CT calcium score is generally described as minimal. The American Association of Physicists in Medicine came out with a statement helping all of us understand the risk-benefit ratio better. The statement basically says that within the radiation ranges that CT offers, not just calcium scoring, which is very low dose, the risk-benefit usually is by far outweighed by the benefit you would receive from the information from the test compared to the risk.
So with regard to the information that you get from the test, let's say I receive my cardiac calcium score and I want to discuss it with my primary care physician. The purpose of that would be to identify whether I'm at risk of having a cardiac event. Is that correct? And if I am at risk, to take steps to reduce my risk?
Yeah, let me put it my way. We all are at risk of having a cardiac event, and we all will die. Hopefully not too soon. But without joking, our risk can be very small or it can be high. And if you look at an individual, there are certain things like our age, our weight, whether we have diabetes and so forth, that our gender, that help our physician to judge where we are compared to other people. Mm-hmm. Often the word percentile is used. Now these clinical findings, things like our weight, if we have diabetes or other disease, if we are smoking, our age and gender, they are relatively good, but they are substantially enhanced by adding a calcium score. So if you are in the intermediate risk category, the calcium score can help you reclassify into a low risk or a high risk, which then will help guide your physician to create a therapy individualized to you. You can think of it as higher precision medicine.
I see. You had talked a little bit about the radiation exposure involved in a CT test. I suppose that this involves a CT machine, am I correct? And that's what most people associate with like going into a donut hole. Is that a good way to describe that? My mother is claustrophobic. What if she were to come in and ask for one of these tests? Is there a way that she could take a test like this and not have an anxiety attack over being inside that machine?
Okay, that's a great question too. Nearly always there is no problem with claustrophobia in CT. In medical imaging, we have different types of donut holes, and it is MRI that has these longer tubes that are associated with claustrophobia. Most CT machines are very short donuts, thinner donuts if you wish so. And they're very open, and therefore incidence of claustrophobia or patients feeling uncomfortable are extremely rare to unheard of. Many sites have never had a case.
How long does the test take?
Another good question. There are different answers. The acquisition itself is extremely fast. It is seconds. It can be, depending on the scanner, it can be 1 second or 5, generally less than 10 seconds. However, EKG leads have to be connected to you. You have positioned, the scanner has to create what we call scout images. They look like an X-ray, so you know where the heart is. So you're scanning only the heart. So you can plan on being in and out of the CT room in probably 15 to 20 minutes, and there may be some extra time just changing and getting ready to get into the CT room.
And do you have to lie perfectly still while you're on the exam table?
Yes.
And hold your breath?
We would need, so it is in your best interest to lie as still as you can for the 10 seconds of the acquisition, or at most 10 seconds, and you will be required to hold your breath, so you have to be able to do a 10-second breath hold during the acquisition.
We have another question from one of our audience members. Do you think this type of test should be part of the regimen for care of women who post breast cancer have been on estrogen-reducing medications. There seems to be a relationship between these drugs and cardiovascular health. What's your opinion on that?
Wow, that's a great question. I don't have a great answer for it. I'm going to be open with you. This is a great question for our provider, for your provider. They will assess your risk. In general, women are at higher risk for cardiovascular disease than we society have recognized. This is not a disease that just occurs in men. So women should be considered as much as men are. And in this particular situation, if there were, for example, radiation therapy involved in the treatment, in addition, there is accelerated atherosclerosis, so the risk is higher. I don't know specifically in which situation this test would be useful, and I do not want to give information out that I'm not 100% certain. So I would recommend you review your risk with your provider to help calculate, to help know whether having that incremental information will help reclassify your risk for coronary artery disease.
Well, getting back to the test itself, so we talked a little bit about how much time it takes for the test, how you take the test. You know, you have to lie perfectly still for the time that the images are being captured. How do you prepare for a test like this? Do regular medications have to be stopped beforehand?
Okay, that's another great question. Now, my answer will be for calcium scoring only. It's different for coronary CTA, so the answer is only for calcium scoring. For this test, preparation is very easy. You don't have to drink any barium. You don't have to take any medication. We will
So no contrast agent goes into the body for this?
No IV contrast agent will go in the body, and we don't slow your heart rate. We do ask that you do not smoke the day off, or at least 4 hours prior, and don't take any caffeinated food or drink, because that might increase your heart rate, and therefore the images may be more blurry. And then in general, whenever you get a CT scan, please don't apply any powder or lotions to the chest, because that can cause some artifacts.
So will the individual undergoing the test need to have someone take them home afterwards, or can they resume normal activities?
Because we don't give any medication, the person can get off the scanner and resume normal activities immediately after the scan.
So I think that's a point of confusion for some people, is the difference between the scoring test that we're talking about today and the CT angiography, which you began discussing. One is something that would require that the heart rate be slowed, and that might be done through some medication, and there might be some lingering effects of that after the test. But for the test we're talking about today, the cardiac calcium scoring, none of those things that we associate with CT angiography would apply to this particular test.
Right. So it's a very simple procedure to go through.
And how soon before a patient will be able to get results that the patient can discuss with the primary care physician?
Right. So at our institution, we turn these around within a working day. Usually we'll have a report back to the primary care physician within the same day.
I see. Okay. One question that constantly comes up when we're dealing with patients is the question about insurance coverage. Does insurance cover this type of test?
Unfortunately, a lot of insurance don't cover the coronary artery calcium score alone. We offer a $99 calcium scoring, so if your provider, your physician, feels this is a test that's good for you, or if you feel this is a test that's good for you, you could pay $99 and get the test at UT Southwestern. I want to add, though, that if you get a coronary CT angiogram, some of them have that calcium scoring test included, so you get both.
Get both at the same time.
And those are a lot of insurers do pay. But I would recommend to check with your insurance company, make sure that they do provide it.
Okay, and so once again, you said that here at UT Southwestern you can get a cardiac calcium scoring test performed for $99 as an out-of-pocket expense. That you should check with your referring physician or your primary care physician to see if this test is right for you, if you're at higher risk of developing coronary artery disease, and if this would...
Intermediate. If you're in the intermediate risk group.
I see.
Yeah, this test is, I'm sorry, I don't mean to interrupt you, but test is best for those of us that are in the intermediate risk group. If you already are in a higher risk group, your provider knows what to do. They would be more aggressive with things like Lipitor. And if you're in the very low risk group already, your provider has a good guidance. But the intermediate risk group, which is a large number of us, will be most likely to benefit.
So you mentioned a few of those things that would put a person in that risk group.
Mm-hmm.
Weight, diet, smoking habits, alcohol consumption, kind of the things that you would typically associate with, being in a risky category. Are there any other things that we need to know about that would put someone in an intermediate risk category?
So there are a number of others. I would recommend that everybody discuss that with your provider, but a typical one would be your cholesterol and LDL above 160 or so would put you in the category. Hypertension, if your blood pressure is higher than 140 over 90, for example. And then there's a few other conditions that you may have that would place you in that category. And age and gender is important.
Family history of heart disease?
Right, family history, yeah.
And what age should a person first consider getting a cardiac calcium score?
So the earliest age you would, if you're male, you would consider is age 40. If you do it earlier than that, a lot of us have a calcium score of 0. Most of us will have it, and it is not very meaningful to have the number. And if you're above 65 or 70 in female, calcium score is not as effective because given our age, we will be in the high risk category. So between 45 and 65 would be the core, or expanded to 40 to 70 to include both genders on both sides.
And being physically active is no guarantee that you don't have a buildup of calcium plaques in your arteries. Is that right?
Yeah, unfortunately that is true. So you can live very healthy, and yet you can have coronary artery disease.
As you said, it's asymptomatic.
Right, lifestyle is one, but our genes are another part that affects our risk. And this test is the only test that allows us non-invasively to quantify coronary calcium.
I see.
Aside from CTA, which allows us to look for more than just calcium.
Well, so we have just a few minutes left for our chat, Dr. Ibarra. We want to thank you so much for your time. I asked the question about physical activity and how it's not really a guarantee that you don't have a calcium buildup in your arteries, or calcium plaques building up in your arteries, because a couple of weeks ago there was a report here locally on our public radio station about a study that was being done where they looked at the arteries of 50 men who were marathon runners, and they said that even in this relatively healthy group of men, that ran an average of 25 marathons in their lifetime, they discovered calcium plaque buildup in their arteries, which was quite surprising to them. So I just wanted to bring that up as a topic of discussion, that even if you think you're doing everything right, because this is an asymptomatic disease, it's going to be important to take whatever preventive measures you can, and certainly a test like this would be a preventive measure.
Yeah, that's exactly right. So asymptomatic or people with no symptoms is what we're looking at, because we're looking at people a long time before a heart attack would happen. At a time when you still can make lifestyle modification that will affect your risk. You can't reduce the risk to 0, but you can reduce it from whatever it is for you personally. So we're looking at a long time before symptoms appear. Now, I'd like to point out one more thing. So what calcium score should you be hoping for? Well, I would be hoping to have a calcium score of 0, which means no calcium was detected. But I want to caution us, a calcium score of 0 means we have a very low chance of having a cardiovascular event in the next 1 to 5 or so years. A very low chance, but not 0. A calcium score of 0 is not a guarantee that you won't have an event. It just means that your risk is the lowest compared to people that have a calcium score of non-zero.
So if it's discovered that there is calcium plaque buildup in your arteries, can you live with that? Can you live a long life with that if you make certain lifestyle changes to reduce your risk?
Yes, calcium in coronary arteries is very common. We all have it. I don't know if I had it. I didn't have my calcium score yet, but I may have a calcified plaque. And a lot of us will die of something else, of old age maybe, despite having calcium. What the calcium score tells you is your risk of developing the disease in the next few years, which if you look at all of us is relatively low for all of us. And you will know if your risk is higher than the next guy or perhaps lower than somebody who's like you otherwise.
So in the same way that water can still flow through rusty pipes, blood can still flow through arteries that have calcium plaque buildup.
Yeah, I guess you can think about it like that.
Okay. Well, I just want to take one last look at our questions that have come in. Looks like everybody's had their questions answered for now, so I just want to thank you, Dr. Ibarra, for spending some time with us on this chat. I want to thank those folks who were following along. Of course, we've been recording this live chat, so it will be available for those who weren't able to join us today. I want to thank you for joining us, for asking great questions. Don't forget that this chat will be available here on Facebook and will also be on our YouTube channel later today. That's youtube.com/UT Southwestern Radiology _videos. So please share this with your friends and loved ones so that we can help spread the word about the importance of cardiac calcium scoring. It could save a life, and that life could be yours. Thank you very much, Dr. Ibarra.
Thank you.